Hello, my name's Tom Walker. Welcome to this podcast. I'm going to be talking to two people about the benefits of taking part in clinical research. Recruiting participants for research can be difficult, especially when they might not benefit directly from it. So hopefully, once you've listened to this podcast, you'll understand the challenges and why it's so important to get involved. Let me introduce you to the two people who we'll be hearing from. Jasleen Jolly is the Assistant Professor in Multi-disciplinary Vision and Eye Research at Anglia Ruskin University and the University of Oxford. Jasleen's work involves gene therapy for treatments of genetic eye disease, the neuroscience of low vision, and the psychological impact of visual impairment. For new treatments to be successful, a lot of background work has to be done to provide the required information to develop the new therapy and also know how to test it. That is why research which does not give direct personal benefit to the participant is so important, and why without this work the new treatments would not be possible. And the second person I want to introduce you to is Dr. Andrew Mitchelmore. Andrew understands why it's important to take part in clinical research and has participated in research which he hasn't directly benefited from. Andrew has the eye condition choroideremia, which is similar in some respects to retinitis pigmentosa. Andrew is a senior lecturer in health and exercise physiology at Oxford Brookes University. I started by asking him to tell me about his research interests.
I'm a senior lecturer at Oxford Brookes. We're lecturing pretty much anything health and exercise physiology related. So we do a broad range of clinical conditions on our courses at Oxford Brookes, and also teaching on modules relating to things like determinants of health and maintaining health across the lifespan, physiotherapy, and all of those sort of exciting topics. So I have choroideremia, which is a genetic eye condition, and Jasleen is one of my clinical points of contact, who I've been in touch with now for about 5 years or so, I think, which is quite scary. But yeah, Jasleen has been working with me as a researcher and in a clinical role as well. And yeah, I've got a big interest in sort of the research side of things, because obviously I do clinical research myself from the researcher side of the desk, and then I'm a research participant on the participant side of the desk as well. So I get to see both sides of the process, which is a fairly unusual experience, I think, for most people.
Dr. Jasleen Jolly, you've just been mentioned there by Andy, so I think it's time for you to introduce yourself as well.
Hi, thanks Tom and Andy. I am an associate professor in the Vision and Eye Research Institute, Anglia Ruskin University, and I've just come from Oxford University, where I was involved in the gene therapy trials for choroideremia and RP. And I do a lot of the background work for the gene therapy trials on how to measure the impact of the therapy so that the trials are far more effective. And I also look at the visual pathway as a whole. So what happens when you've got eye disease to how that information is processed in the brain. And then the third part of my research is the psychological impact of visual impairment.
Jasleen, thanks very much for now. We'll come back to you in a few minutes. Andy, you said in your introduction there that you're a researcher. You've done quite a lot of research over people's sedentary lifestyles during the lockdown, haven't you?
Yeah, so I mean, my background traditionally was research looking at arterial health after stroke, so central and peripheral blood pressure measures and measuring central pressures non-invasively. But whilst COVID-19 has been obviously very difficult for myriad reasons for absolutely everyone, it has created an entirely new research area, which it's afforded us some opportunities to create some novel research. So yes, we've been doing some research into physical activity habits and mental health as a result of the COVID-19 initial lockdown, so looking at the UK versus Australia and New Zealand. And at the moment, we're looking at mental health measures in people with long COVID who have sensory loss, so the loss of or altered taste and smell, and how that over a long period of time can affect your mental health, because it's not getting a huge amount of attention at the moment compared to some of the more obvious physical manifestations of long COVID, so through the fatigue and the more traditional post-viral syndrome symptoms. So that's kind of a whistle-stop tour of the research background, but there's just so much that needs to be done at the moment in this topic area. It's a bit of an untapped area at the moment because it's such an unknown, because it's all still going on, unfortunately.
I was interested in it because a friend and I, we used to go walking during the lockdown, probably unusually for visually impaired people, and we'd share with each other how many steps we'd done each day. I think I got to 20-odd thousand steps one particular day, but I realised that isn't typical for most blind and partially sighted people. You mentioned there your eye condition, which is extremely difficult to say. I'm going to have a go at it. Choroideremia. Tell us what that is exactly, Andy. What effects, what practical effects does that have on your day-to-day life?
Yeah, so I was diagnosed in March 2016. I think it was sort of mid to late March 2016. Went in for a standard eye test, an eye checkup, because I knew I needed glasses or contacts, but I'd done the typical thing of just putting it off and just dealing with not having great vision. And did the field test and completely and utterly tanked it. So the optician who was running this test was initially not sure I understood the principle of pressing a button when I saw a dot, and explained it a few times, and I did reassure her that I understood the concept, but just didn't see any dots appearing. And then had a meeting with an optician. I won't name the opticians I was with because I don't see them too favourably. But the optician got very excited because I direct quote, "Oh, I think you've got the condition I did my dissertation on," which wasn't a brilliant way of finding out that I had potentially a life-changing diagnosis when I thought I was just going into the opticians for a standard eye check and to get some glasses. But yeah, day to day, it manifests in the earlier stages as blind spots on the periphery of the vision. So I know that I've got complete blind spots just off center, sort of laterally from the eyeball, from the center of the eye in both eyes. And my actual extreme peripheral vision's all right towards the very edges of my vision, but there are some blind spots sort of scattered about. As the disease progresses, those blind spots essentially start growing and joining up until your peripheral vision is entirely gone and you're only left with your central vision. And then slowly that central vision degenerates as well. So eventually, completely depending on the course of the condition, it does end in blindness inevitably at the moment, although obviously these gene therapy trials are working towards ending that as an inevitability. But day to day, it's most noticeable in terms of night vision, in terms of sort of stubbing your toe on things or kicking things on the floor, not being able to find things on a desk in a rush when there's lots of little items on a desk. It takes a little bit longer to find it. Just little annoyances, but then as the disease progresses, those little annoyances become slightly larger issues, and obviously then start affecting your ability to even get out and about in the later stages of the condition. But at the moment, I believe I'm still classified as fairly mild and they think slow progressive, although there's still a fairly small sample size of annual checkups for that. But yeah, it's a pain at the moment, and it does affect things. So I wouldn't do, go-karting, paintball, that sort of thing. I can't play squash anymore, but I can still live a relatively normal life at the moment with just a few extra considerations here and there.
I know you're not an eye specialist, but I'm guessing from what you know, you would regard it as being fairly similar to retinitis pigmentosa?
Yeah, so depending on the clinician I speak to, I get a slightly different definition here. So some of the letters I get still refer to my condition as having retinitis pigmentosa, but I think technically choroideremia is a condition outside of that remit. I think from the frown on Jasleen's face, the letters shouldn't be saying that at the moment. I can see on Zoom that she's agreeing that it's a slightly different condition. But to my knowledge, it is a similar-ish condition. I mean, as a patient, the precise classification, if I'm honest, doesn't mean a huge amount to me. It means a lot more to the people who are working with me and treating, for want of a better word, me. As a patient, that classification becomes less important, I think. But it's similar to RP.
Now, you've been involved in research with Jasleen. Tell us about the research you've been involved with and what that's entailed for you personally.
Yeah, I've done a few studies with Jasleen now, and it normally involves a nice wander into John Radcliffe Hospital because I live fairly locally, so it's quite an easy commute. And then I just spend half a day or a day with the lovely lady herself, being poked and prodded and put in an MRI machine from time to time and doing different tasks. And it's not been anything invasive. They've all been non-invasive research studies. And honestly, I don't see any reason not to do it because all it costs is a bit of time. It's something a little bit different to do with your day. It's outside your normal remit. It's nice to have an afternoon out of work occasionally to get away to do something different, although maybe I shouldn't be saying that when this is not being recorded. But it normally involves a number of retinal scans, a number of usually cognitive tasks, sometimes while an MRI is being taken. It's a mixed bag. It's been, I don't know if enjoyable is the right word. It's been as enjoyable as it can be when you are a clinical patient in a research trial. I've actually had quite a nice time doing them at times. And obviously I've made quite a nice friendship out of it now because I'm not Jasleen's patient anymore. And we're able to have a good friendship based off those first interactions. But yeah, it's normally half a day to a day and then doing a number of tasks and just being observed and scanned at the time.
You mentioned there the MRI scan. For people who haven't been subjected to that, for want of a better expression, could you describe what it involves and whether people should actually be worried about it in the first place?
Certainly can, yeah. So MRI, it stands for magnetic resonance imaging. And essentially it's I guess you lie down normally if we're looking at the brain, which I've tended to with Jasleen. You lie down and essentially get moved into what is essentially a large tube. And some people say that they have found it claustrophobic. And I think that's only an issue if you don't really know what to expect. I think, you essentially lie on your back, get shuffled slowly into a large white machine. Your head is kept as still as possible, so you get nice, clean images of the brain. And then there are just some standard noises and clunks as the machine does its thing and scans your brain. So depending on what you're doing, the duration, I think the longest I think I've done is about 45 minutes, an hour off the top of my head. And you eventually just have to lie as still as you can. Sometimes you do tasks on a computer. You can see you've got a mouse in one of your hands. And you just lie as still as possible and try not to think about your nose itching or anything along those lines, and do as you're told. You're in constant communication with the people who are running the tests. So there are speakers inside the MRI machine and they can hear you as well. So if there are any issues, you can get in touch with them immediately. They're only a few meters away on the other side of a wall. And they can keep in touch with you and give you updates about exactly what's happening, how long it's going to take, what they want you to do next, etc. And genuinely, the hardest thing about it sometimes is staying awake because you're lying still for such an extended period of time, being asked to not move. It's very difficult to keep your energy levels up in that situation. But I quite enjoy them because there's something a little bit different, and it's not stuff you get to do on a day-to-day basis. And I find it quite interesting and exciting anyway, and I'm exposed to quite cool bits of clinical equipment on a day-to-day basis anyway through my job. So for someone who's potentially not even working in this sort of field, I'd imagine it would be fascinating to kind of get an inside look at some of the equipment that's used in the hospital environment, because it's staggeringly clever, honestly. It's fantastic.
From your point of view then, is there anything to worry about at all in relation to being fed into the MRI scanner?
I genuinely don't think so, no. I think if you don't know what to expect when you turn up and you haven't looked at what an MRI actually involves and you don't know how long you're going to be in there for, getting laid on your back and then sort of slowly shuttled into a large machine, I can see how that would be intimidating. But if you are reasonably informed before you come in, if you ask questions of the researchers before you take part in the study, which is something a lot of participants are reluctant to do, is to ask questions. If you do that beforehand, if you do read the information sheet, which again, a lot of participants don't do, and I do include myself in that sometimes. If you don't know what to expect, I can see why it would be intimidating or scary, but if you turn up fairly informed and you're not afraid to ask questions, and you just remember that, you know, nothing is going to go wrong while you're in there. It's kind of just like being in a sleeping bag. That's how I see it. You're just lying in a sleeping bag for an hour, but it's a 360-degree sleeping bag, so it's over you as well. You've got, you know, it's not literally crushing you into this machine. You've got a little bit of space to move. It's not like you literally can't move in there. If you go in and see it in that sort of aspect instead, it's a lot less intimidating and scary, I think. And once you've done it once and you know what to expect again, then it loses that complete, I guess, intimidating stigma completely for me. I mean, I was, slightly nervous the first time I had one because I hadn't had one before. But yeah, I could spend quite a long time in there quite happily now, as long as I was allowed to have a nap.
For people like Jasleen, research is critical to advance knowledge. What do you get out of it? Because you don't always benefit directly, do you, from the research that you're involved in?
No, absolutely not. And I think that is a difficulty in recruitment to research studies as a whole, is this whole no direct benefit. And it's a question that gets asked by ethics committees sometimes as well when you're passing or trying to get research studies passed before they begin, is, you know, where's the direct benefit to participants here? And honestly, the answer is sometimes there isn't a direct benefit. I mean, but for me, these sorts of studies are, you know, maybe there won't be a cure or a treatment for my condition in my lifetime. I have no idea. I'm hopeful there will be. And, you know, the noises I've heard are fairly positive so far, but there's no guarantees in this world. But if I want to have children, if I want to have grandchildren in the future, potentially, if everyone does their little 1%ers, like by taking part in these research studies, my kids, my grandkids in the future aren't going to have to go through what has been at times an extremely difficult situation. I mean, all of these clinical conditions that we can now vaccinate against, or we can treat, that's only possible because of research studies in the last 100, 200, 300, 400 years, especially in terms of vaccinations. You look at, you know, you talk about no benefit. Try looking at research studies on vaccinations 200 years ago where people didn't know if they were going to die or not when they took part in the study, and people still did it. Yeah, the no direct benefit is a difficult one, but I try and kind of zoom out from it and just say, well, just because there isn't a direct benefit to me doesn't mean there isn't a benefit. This research wouldn't be taking place if there wasn't a benefit. Ethics committees don't pass research studies if there is no benefit to them taking place. It might just be a benefit in 10 years' time, 20 years' time, 100 years' time. We don't know. But yeah, I find that a bit frustrating when people say, oh, there's no direct benefit to taking part. When you're researching with clinical groups, I do sometimes think it's easier to recruit because people are motivated to take part because it's a research study that is working towards creating a treatment or a cure for a condition they've got. Personally, from personal experience, I found it's more difficult to recruit participants who are maybe a healthy control group, for example, where they don't have the condition being investigated. They're really being recruited as a comparison group. But to that sort of population, I'd say, well, firstly, it's an interesting experience to be a part of a research study. I think it's something that everyone should do at least once, just to get an experience of it. And I think you never know which of these conditions are going to affect people in your family, are going to affect your friends. You have no idea which of these conditions you're going to come across in your lifespan. And if everyone did it's kind of like giving blood. If everyone did their 1% contribution or their 0.1% contribution or their 0.001% contribution of doing this tiny act, if everyone did that, the benefits add up so quickly. It's kind of like voting, isn't it? You only got one vote. Does it really count for anything? Yes, it does, because if everyone contributed and everyone used their vote, it makes a big difference. And it's kind of the same sort of principle, I think, where, there is going to be a benefit from all of these research studies in the short or long run, and you never know when or where that is going to benefit you. And it might be someone you meet and decide to marry in the future maybe ends up with a condition you were a participant for a healthy control group for 20 years earlier. You don't know if any of your best friends are going to get diagnosed with one of these conditions further down the line. You just never know. And as I say, the main message for me is that no research studies don't have benefit.
Okay, Andy, thank you very much for the time being. Jasleen, we've heard Andy there talking about the benefits, direct and indirect, of taking part in research. What issues do you have with recruitment of participants?
Yeah, patients are often very keen to take part in the interventional trials, so where they're getting a treatment, but don't always want to give the time for these other studies. But from my perspective, the other studies are essential for the interventional trials. So up to a third of trials for new treatments fail because they're using the wrong outcome measures. So the way they measure the effectiveness of the treatment it isn't good enough or isn't appropriate to pick up those changes. And then you can't meet the requirements for the regulatory authorities like the FDA, the EMA, NICE. And then you can have the best treatment in the world, but if you can't prove it works, then it's never going to get accepted as a treatment for patients in the NHS. So that's why a lot of this background work is really essential. And I don't think people always realize that. And so sometimes it can be quite hard to get people on board because they don't see how much background work is needed. They just want the treatment.
I'm presuming you have numerous conversations during the course of your working week with potential patients, participants, and you're trying to persuade them to take part. What do you say to those people when you're having those conversations?
Yeah, it's quite difficult. I mean, it depends in which capacity I'm talking to them, because when I'm in clinic and I'm part of the clinical care team, I cannot put too much pressure on an individual because it wouldn't be fair and it becomes a conflict of interest. When someone's approached me about interest in a study, but then they need persuasion to take part, then I can come in and be more persuasive. But in the clinics, there's a limit to what I can say. So this is why I think it's important to raise the general awareness amongst people about the importance of being part of studies. And it's not just the patients for healthy controls. I often ask relatives who aren't affected, who are coming in with with their relatives, with their partners, with their friends into the clinic, whether they would be also willing to give us some of their time to do some of this work. So I do try and explain why I'm doing it, where we think it's going to lead, where it fits into the grand scheme of things. But especially when you're at the beginning of the research journey, it can often be you need years and years of evidence, looking at things in many different ways before you're ready for the treatments. And I think that can put some people off because they don't see that straight road that's nice and timely.
Where do you go to look for patients? I mean, which publicity avenues, if you like, do you explore?
I primarily go to patients in our clinics and anyone who's registered an interest in taking part in research. We have a database. Then I approach charities. I will contact newsletters, try and get the word out there on social media. So a couple of my patients have been really good and helped to advertise studies on Facebook for me because I'm not on Facebook myself, and I'll put things out on Twitter. Any networks that I am aware of, I'll ask them to advertise on my behalf. It's difficult. Like, we try to target as many places as possible, but I don't know whether we're always getting to the right places, getting our voice heard by the right people.
And what sort of research programs are you running at the moment for which you're actually looking for visually impaired people? Is there anything right now where you think, we could really do with some people to take part? We're
recruiting for an MRI study looking at Charles-Bonnet syndrome. So we're trying to identify where in the brain the Charles-Bonnet hallucinations actually occur. Because if we know that knowledge, we can get the disease taken seriously and get people more help, and also know where we start to look for a treatment.
And there's a fabulous organisation called Esme's Umbrella, who I'm guessing you're in contact with.
Yes, they've part-funded the study and they've been incredibly supported. Judith is absolutely incredible. So that's undergoing active recruitment at the moment. And then most of my other studies, I tend to capture people when they come into clinic. So this is how Andy got involved in the first place. He'd come in, and while he's waiting to see the doctor or have some of the tests, I'll often ask people, like, would you spare me an hour either now or later so that I can run some other tests and collect the data at the same time as the appointment?
So what would you say to any visually impaired person right now who's thinking, should I, shouldn't I, not really sure, will I benefit myself? What would you say to them right now?
Please get involved. This is your opportunity to ask people who are experts in your visual condition questions. You don't get this much time with a professional in a standard appointment. So, we want to help you. We want to support you. And we need your support to be able to do that. But also, I may not be able to give you a treatment there and then, but I can give you information. I'm happy to answer any questions about what's happening, about your disease, about show you some of the test results, all of these things that don't normally get enough time in the appointment. And because I'm low vision qualified and have been working in low vision clinics for 18 years, I always try and help you with any other issues that you might be having, any practical problems. I can direct you to services as an added benefit for you giving me the time for the research. I will try and give you more of my time to support you in other capacities as well.
So even if they don't find a cure or whatever for your particular condition, you will still at least try and enable somebody to find services elsewhere, support or whatever it might be?
Yes, I can use my low vision background in low vision care to direct people to appropriate services, give them advice on practical lifestyle changes that might help them cope better. And I feel like that's the least I can do. But also, if you have any questions about your condition, about where things are heading, I'm happy to answer those during the research appointment. So we try and give as much to the participants as we can, as much as they're giving us. So I like to think of it as a two-way relationship.
Now, this is a bit nerve-wracking for me because if I remember correctly, I think you wanted to ask me a question, and I much prefer asking the questions rather than answering them. So, Jasleen, go for it.
Yes, Tom, I was curious about what kind of research you've been involved in and what has drawn you to it or away from taking part in research?
Well, when I was a student, I did psychology, so I was involved in a lot of undergraduate research then, but that was unfortunately an awful long time ago. Haven't been involved in much research since, and probably one of the reasons I was asking you about publicity was because I don't think I've ever really been aware of any research programs going on, and perhaps one of the things that I could help you with is thinking of other avenues of publicity so that we can try and draw in a few more visually impaired people and at least make them aware of it. So maybe that's what they call an offline conversation.
Absolutely, that would be wonderful. And also a lot of research programs, especially in more rare conditions, are open to people from all over the country. So I have people traveling in literally all over the country. We often, when we apply for money to run the research, we cost in travel funds so that we don't leave anyone out of pocket for traveling in and coming and participating in the study. No
geographical limitations then, or not many anyway?
Not many.
Well, look, it's been really interesting to talk to you both, Jasleen Jolly and Andy Mitchelmore. Thank you very much for your time. And I just hope the people who are listening to this podcast feel motivated to get involved. Jasleen, Andy, thank you very much indeed. So there we are. That was Jasleen and Andrew talking about the benefits of taking part in clinical research. Now, we thought it might be quite nice to finish this podcast with a bit of music. So we've decided to feature a track by the Gary O'Connor Band called Fun Sponge. Gary himself has choroideremia and understands the importance of taking part in clinical research. So here it is, Fun Sponge by the Gary O'Connor Band.